Okay, thanks for waiting on me. I do apologize. I know this one took a while. That's kind of because it was a mess to put together, as I'll explain in a little bit. But a little background about me on this one. So I have worked as a paramedic on the ambulance and in the emergency room. When I was on the ambulance, it was in a rural area, it was on the I-10 corridor near Houston. We were about 40 minutes from Katy, which was where like the basically like a decent hospital was. And then I worked at Methodist in the South Texas Medical Center in San Antonio after that. So I have quite a bit of experience with all of these concepts, I thought. And do know that a lot of this is coming from a pre-hospital setting, but I do have the ER side of things, which again is very, not exactly a hospital, kind of pre-hospital still. But let's get going. So first, wanted to talk about SIRS, kind of go along with the order in the RRD. So basically, you can have SIRS without infection. We saw that a lot in COVID, where they would test for the COVID with the PCR testing and the COVID, the actual bug, and they wouldn't find it, but the person would be in a systemic inflammatory response. Um, Basically, another word for this is a cytokine storm, which, remember, your cytokines, I call them screamers. They're kind of the things that are your regulating chemicals that talk back and forth. So various factors such as regulatory cytokines, there's one of your helper cells, CD4 cells is a regulator. All those are kind of either ignored, or they're so overwhelmed by either too much damage of the tissue or too many microbes that it just kind of it tips the balance between overwhelming and doing good. Um, and keep in mind that there's a lot of chemicals that are being released at this time that do similar functions. So like your histamine, prostaglandins, and leukotrienes all kind of mess with your vessel tone and permeability, right? And that plays a huge factor when we get into sepsis and shock. So basically, the normal and good parts of our innate immune system become the things that are destructive. So prostaglandins, they're great. They also, but they're also not, because they inhibit production of albumin and I think there's two other intravascular proteins, and that's really, really important. And they really didn't go over that in the first RRD, but remember, they were kind of talking about either protein loss or fluid overload and how those kind of go together. That's because protein, your albumin is what holds, it's the protein that binds the water into the vessel. Sounds kind of weird, but a lot of it has to do with proteins and the ability to keep that fluid into the vessel. And when you lose all of that, there's nothing to keep it there, and so it just leaks out. They're also the main regulator of fever. So if you have a lot of them, it can lead to things like malignant hyperthermia, which is where they have a really, really high fever. 108 degrees Fahrenheit is about the point where your brain starts cooking inside of your body. So obviously not where we want to be. So I kind of, my sad drawings, but with a normal artery, you're going to have, your BP 120/80, right? And what I zoomed in on is what's supposed to be like the actual wall of the artery. And in between each of those cells is what we call a gap junction. And it's what holds it together. And in a normal artery, those are really, really tight together, so things can't just get in and out like neutrophils, right? That stays in the blood. But things such as electrolytes can. It's small enough that it can get through. Well, like I said, there's a lot of chemicals being released that do the same thing, and they're all telling the artery all at once to open up and just relax. So we have these huge, I can't think of the word, gosh, gaps, I guess is the best word. We have these huge gaps where our gap junctions are, because it needs to let the neutrophils and other leukocytes in. The issue with that is that everything is telling it to relax and open. And so it dumps all your fluid out as well, because remember, it's going to follow that gradient. And with all that histamine in that tissue, it wants to follow that. Kind of the same like anaphylaxis, but less about a specific antigen. And that's why I put like blood pressure of 80/50. The issue with that is whenever you go under 90 millimeters of mercury for your systolic, you stop perfusing to the brain, the kidneys, and the lungs. So obviously those are things that we need, and that's kind of where shock comes in and starts shunting things. But there's a certain point where even shock can't help compensate, and that's what we call the decompensation phase. So I went in to look for sepsis because reading what it says, the definition is basically that systematic inflammatory response with infection. I always thought that it was specifically bacteria in the blood, and that is not true. And turns out there's a council on sepsis that has to do with a task, like a European and American task force that defines sepsis and all this stuff. And basically, as I researched all this, I was like, oh my gosh, there's not an actual definition of sepsis. So the definition that this task force gave as of 2016 was a life-threatening organ dysfunction caused by a dysregulated host response to infection. So now they don't even include SIRS in sepsis. You don't have to have SIRS to have sepsis. And so I started thinking back to when I worked in the ER, because we had sepsis alerts all the time. And if you don't know what a sepsis alert is, it's basically a patient comes in and during triage, they hit some sort of marker that the doctor looks at, and the doctor decides. Actually, I think nurses can decide it too. Nurses or doctors are like, this sounds like it could potentially be an infection that's become septic. So we're just going to go ahead and do a sepsis alert. And with that, basically, like, that's why I put we're all going to die, because it gets so dramatic for no reason. But you basically have to add on a bunch of blood work, including blood cultures. And then you have to basically do all these things. I'll talk about it in the next slide, but the surviving sepsis has which is the little link on the RRD. Surviving sepsis has like the recommended first hour what you should be doing. So you have to do all these things, and then half the time, or probably like more than half the time, they're not septic. Um, so that there is no clinical requirement for what sepsis is. Just know it's basically what we define it as is SIRS plus infection. And remember, that can be bacteria, viral, fungal, parasitic, all those things. I think what is hard is working in the ER. You kind of get that all the time. I think on the floor it would probably be a little bit easier because you've been monitoring that patient, but I honestly don't know because I don't work on the floor yet. Anyway, so remember those clinical requirements for SIRS is kind of also the what they use. It kind of depends on the hospital. It depends on the medical director of the ER. It depends on a lot of things. Keep in mind too that your heart rate and your respiratory rate are your go-to functions that change with anything. Like if something's off in your body, the very first thing that happens is like your heart rate changes and your blood pressure changes. So how is it that we can call sepsis when we don't even have like a white blood cell count and all that? That's kind of one of the arguments within the ER. Obviously, if you're on the floor and you have a normal white blood cell count and then all of a sudden it's really high, you can call sepsis. The last part I put Q-SOFA, lactate, IDK, LOL. And honestly, that was just because we don't have an official clinical requirement. That's my biggest thing. Q-SOFA is something that we use in EMS and in the ER occasionally, which is looking at do they have any organ damage or organ dysfunction or organ failure. A lot of people have kind of gone away from that because at that point it's kind of too late when it starts getting to other organs. Lactate, one of the biggest things with sepsis that you'll see is a lactate above 2. That none of that is required. Like you don't need to know any of that. It's just kind of helpful. Basically, lactic acid builds up, and that's in part why we give fluids. So, with that, what happens? Wait, no. Okay. What happens when we call a sepsis alert? So, the surviving sepsis, I can't remember what the C is, whatever the surviving sepsis thing is, they have an hour 1 bundle of care element. Because remember, and this is what I assume they are going to put on the test, the mortality and risk, or in other words, risk of death, increases by 10% every hour that someone is septic and does not get treatment. My thing with that again, at what point do we consider it sepsis? Are we talking about every hour of septic shock? Are we talking about every hour of sepsis? We don't know because we don't even have a definition for sepsis that everyone can agree on. Anyway, so there's a few things that are going to happen. Like I said, everyone kind of like starts rushing around because you're going to need a lactate level. So you add another tube. Blood cultures. If you have never seen a blood culture bottle, they're pretty big. You need at least 5 mLs of blood, but they prefer 10 in each one. So kind of warn your patient when you draw blood like that, because I didn't in the beginning and their eyes would get really big whenever I pulled out the blood cultures, and you have to take 2 sets of them and there's 2 tubes each. So and you want to do that before administering antibiotics, because if not, you get in a lot of trouble. Even though you don't know if it is bacteria or not, they just kind of assume it is. Anyway, so we're going to administer broad spectrum antibiotics and then begin rapid administration of crystalloid for hypotension or lactate level greater than 4, which we never did 4, we did 2, but that was just us. We also never calculated the 30 ml per kilogram. Crystalloids is another word for normal saline, honestly, or lactated ringers. So our protocol was kind of more, as long as they get a bag of antibiotics and a liter of fluids within the first hour, that was the most important thing. And then apply vasopressors if hypotension during or after fluid resuscitation. If they need vasopressors, they are not in sepsis, they are in septic shock, which is completely different, kind of. And we'll kind of go into that. The MAP of 65 or greater, your MAP is just your mean arterial pressure. So either a MAP of 65 or a systolic or top number of 90. Those are your two numbers that you want to hit. Anything below that, your major organs are not getting perfused. For the test, looking at it, I feel like the biggest thing is going to be that we are the key to early identification of sepsis, which is why we can call sepsis alerts just as much as the doctors can. And then again, remember that mortality risk increases by 10% every hour. So we can, and this is true, we really can be the defining moment between life and death if we catch it quick enough. My problem again is, when are we catching it? But it doesn't talk about that, so we'll move on to septic shock. So septic shock, a good thing to know is that any type of shock is defined with a systolic or top number of 90 or below and a MAP of 65 or below. And remember, that's because you're not getting perfusion. So not only do you have that vessel that is just basically pouring out fluid, now you've done a fluid resuscitation, you've given them a liter in hopes of both, I've been told, both washing out the lactate, kind of like diluting the lactate in the blood to help with acidosis. I've also been told that it's to do basically what's called a fluid challenge. If you've ever worked with vasopressors or things that make your blood pressure go up, you have to do fluids before you give that to see if they respond to fluids. And you kind of pray that they do, because that's a lot easier to treat than vasopressors. But also, you give them those fluids to try to put fluid in the vessel and bring things back into the vessel. The only issue is with, obviously, like I said, with SIRS, you're losing albumin, your vessels are being told so many things to just open up and let everything out. So if we're adding more water to it, it can actually do the reversal of what it's supposed to do and go into what's called third spacing, which I'll kind of show. It's a type of edema basically, but it's where like the fluid has no idea where to go and it just goes into the tissue and isn't in the cell, isn't where it's supposed to be basically. Septic shock usually means that there is some organ damage. If there is organ failure, usually it means it's too late. I say usually, that is 100% what I have seen, not necessarily like a rule of nursing. I'm just kind of letting y'all know. Like, once they get to septic shock, it is a very bad thing. If we catch it early enough, we may be able to save them. It does depend on a lot of factors. I worked in a rural county that was, I think the population was like 90% geriatric. And so I dealt with a lot of septic shock because they would get UTIs, and old people and UTIs, it turns into septic shock so fast. Another fun fact about nursing. So they usually were not doing too well. And so I kind of put, okay, but why are they going into shock, right? So cytokines, the other mediators, they make the artery, I kind of mentioned, it just makes it all loose and allows everything to go out. No blood proteins to keep it in. The fluid, the third spacing, has now, it's just sitting in the tissue, but it's also putting pressure on those capillaries, right? So it's occluding blood flow to anything that is, well, anything that has edema to it, but especially your peripheries. And remember, since we're in shock, we've already shunted the blood back to the center. And the idea of shunting with shock, any type of shock, is that the body recognizes that things like limbs are not as important as things like kidneys. And so they'd much rather take blood flow from limbs and put it back into the kidneys than circulate the whole thing. It's a lot less stress on the heart. So it's kind of, it's compensation. We used to think it was really important to get people out of shock as soon as possible, and we kind of realized, like, well, shock is actually like the body protecting itself. So shock is not necessarily a bad thing, but it is a sign of a very bad thing. Um, and so because that fluid sits in the tissue and it's not getting any blood flow, you start losing that tissue. So that's going to start in the hands and the feet. And then, of course, because blood pressure is so low, blood's not going to go to organs, and that leads to what's called multi-system organ failure, and is usually what people die from in septic shock, not necessarily the infection itself. Usually, like, kidneys are first to go, which is really bad because if you remember the renin angiotensinogen system, I still don't think I said that right. Um, anyway, it relies on blood pressure to release. And so all of a sudden, if you have no blood pressure and no kidneys, you have not really any regulation of blood pressure, which is where you get into your vasopressors, or if you've ever heard of Levophed or norepinephrine, dopamine, epinephrine's another one of them. I think there's more, but that's the ones we use in EMS and that I'm familiar with. So, and a lot of the time, unfortunately, those don't work either. And that's kind of how you know, like, oh, this is bad. Um, so just FYI, before I move on to the next slide, I put some pictures in. So if you have little ones watching with you, or you're really bothered by not so nice pictures, that's coming. So going to the next slide. Okay. So up in this left corner, that's kind of the first, it's like a rat, they call it a rash, but it's those capillaries bursting. It's almost like bruising at the capillary level. So, and that's, I mean, just because these capillaries have exploded at this point, they can't hold, like, the pressure from the fluid is too much. They also call it mottling because if you're familiar with the process that takes place after death, the first thing that happens is your skin mottles because it's not getting not mottles with a T. Sorry, I have a hard time with that word. The skin, like, turns grayish and starts getting that, it's called purpura, and gets that, like, purplish color because there's no blood, right? The heart stopped beating. We see it in septic shock because the tissue has put too much pressure, and so we're blocking blood flow, and because there's no blood pressure. The fingers, this next one to the right, this is a before and after. This person actually survived sepsis but lost their fingertips. I've noticed this happens a lot with bacterial meningitis. I don't know enough about it to tell you why, but it is like I have heard of so many people losing limbs from bacterial meningitis, which is also why we get vaccinated for it because it's a terrible thing. But you can see that because of that blood shunting and because of, you can kind of see how, like, comparatively how swollen she is. And I say she because this was from a news article and it was a female. Um, so this is necrotic tissue at this point. This isn't the purpura that I was kind of talking about. This is at the bottom. This is third spacing, or you might hear it called edema. It doesn't. They're kind of interchangeable. They're kind of not. These, if you see where the person has put their fingers, that's called pitting edema, and there's like a scale that you'll use that will get taught of, like, depending on how deep you go and how deep it stays, it's like pitting edema plus 4, I'd say, on that one. Sometimes with it, like, sometimes it comes back and then sometimes it just stays that way. It's really freaky. It can also leak out of the tissue or weep, called weeping edema. Third spacing, really, you can see that it hasn't done that in that picture, and that's kind of like the third spacing. It doesn't tend to weep like that, and it tends to be like, example, I had a lady come in from a nursing home who had third space literally everything, everywhere. Like, she was normally this tiny 90-pound little old lady, and she looked like she weighed easily over 200 and was very overweight. And it was because she had no fluid in her vessels. It was all in her tissue. It was the craziest thing I have ever seen. When we put the blood pressure cuff on her, that's how we could tell how small she actually was, because when it squeezed and then released, you could actually see, like, how she would look normally, like with the muscle and the, like, bone kind of thing. So sometimes you can, like, push it and it doesn't pop back like edema does. I think the biggest difference, if I remember correctly, is third spacing. The fluid has nowhere to go, and so it just sits in the interstitial space, whereas edema is more like inside of the cell. I could be wrong on that, but most of the time you'll just hear edema. I didn't hear third spacing until I was in paramedic school, so that may be just an industry term, not really sure. But I hope this was helpful. If you have any questions, let me know, because I know I kind of went off from what the RRD said. There's just not a ton in there about all of it, but all of it is really important, and each one is a very different step. So again, remember, your SIRS can happen without septic shock. That's kind of new. That's the COVID thing. So we've kind of, that's where I first heard it, actually. I had never heard of it with sepsis, but we dealt with that with COVID quite a bit. So next, I'll talk about some of the conditions, and then we will move on to our RD. What are we at? 5, maybe? All right. Thanks, guys.